Good afternoon, and welcome to our virtual program, Headache and Seizures. We are very grateful to have Dr. Rachel Penn and Dr. Felicia Glicksman with us today. A little bit about our speakers. Dr. Glicksman is a board certified pediatric neurologist at the Joseph M. Sanzari's Children's Hospital in Hackensack, New Jersey since 2009. After graduating Binghamton University, she attended Nova Southeastern University College of Osteopathic Medicine. She completed her pediatric residency and child neurology fellowship at Cohen Children's Medical Center in New York. She is the director of the Pediatric and Adult Concussion Center at Hackensack University Medical Center. She is heavily involved in medical education and is the vice chair of medical education in the Department of Neurology at the Hackensack Meridian School of Medicine and is a member of the undergraduate education subcommittee at the American Academy of Neurology. Dr. Rachel Penn specializes in the treatment of pediatric seizures and epilepsy. She completed her pediatric neurology training, followed by an epilepsy fellowship at Johns Hopkins University prior to joining Hackensack Meridian Health. She serves as the Director of Pediatric Epilepsy at Jersey Shore University Medical Center. Dr. Penn is committed to the expansion of the epilepsy program, including the building of the Pediatric Epilepsy Moderating Unit, and is heavily involved in teaching with both students, residents, and fellows. So at this time, I will turn it over to Dr. Glicksman.
Thank you so much for the really nice introduction, Allison. If anybody cannot see the slides, just put a message into the chat. So hopefully everyone's able to see them now. So my talk is focused on headaches in children. And everybody should know that headaches are very common in children. And when they do occur, we know that it can affect daily lives, not only theirs, but their families, and also affect school. Most headaches are not serious, but it is important to recognize warning signs. And that's what we will be discussing today as well. So how common are headaches in children? So I did put in some statistics, but 40% of children will have any type of headache by the age of 7, and 75% of children by the age of 15 will have a headache. This frequency is much higher in teens, probably due to more heavy backpacks, stress, anxiety about school, sports, a whole bunch of different factors, which we will discuss later as well. 10% of school-age children will suffer from migraines, and 28% of adolescents ages 15 to 19 will also suffer from migraines. So when you do see a physician, we do tend to ask about family history, and that will help guide us with prognosticating for your child as well. So if both parents suffer from migraines, your child is at 70% chance risk of having migraines as well. And if there's one parent, there's about a 45% risk. In childhood, there's an equal distribution between males and females with headaches, but in adolescence, there's a bigger predominance that it affects females. Most common causes of headaches are migraines, tension type headaches, headaches caused from head injury, and headaches from illnesses. So for us, that helps us guide our questions when we see you, whether it's with your pediatrician or with a headache specialist, into determining if this is what we call a primary headache or a secondary headache. And it helps us, again, help decide treatment and help with prognosis. So some common triggers for headaches would most commonly would be stress or anxiety. We may ask about abuse or bullying in schools. Sometimes puberty and your menstrual cycle could be a trigger for headaches. Some people who are on oral contraceptives can get headaches. Physical exertion, fatigue, a very big thing in our pediatric population, could be a cause of headaches. Some headaches are brought on by bright lights or flashing lights. Different foods, so foods that have nitrites, such as processed meat, Chinese food with the MSG, caffeine use. So, very commonly, I will ask my patients, it doesn't matter how old they are, I ask about those Starbucks and those trips to Dunkin' Donuts for those refreshers. And a lot of times people don't realize that those refreshers have caffeine in it. So, really asking and being conscious about those trips to Starbucks and Dunkin' Donuts, tyramine and very salty foods, hunger. So hypoglycemia can cause headaches. Heavy perfume use, big trigger for people with migraines. Dehydration, poor sleep hygiene. A very common question that I ask is, what time do you go to bed at night? And then I see the kids and the parents all looking at each other and rolling their eyes and laughing, because they know that that's a big trigger. And then any illness, whether it be viral or a bacterial illness, can also trigger headaches as well. So, when should you see your pediatrician? So, if the headaches are daily, day in, day out, doesn't matter what's going on, definitely should go see your pediatrician. If headaches are caused by coughing or sneezing, or if you're running and every time you bounce it causes a headache, or you get headaches with bowel movements and that's straining, if there's a pain that occurs by the eye, by the ear, if your headaches are associated with confusion or nausea and vomiting, sensitivity to light and sound, or if you're taking Advil or Tylenol and they just keep getting worse, and despite that, either they don't go away or they are getting worse despite medication use. If you have a headache because of a head injury, you may have a concussion, or if your headaches are severe enough to wake you up from sleep. When should you bypass that pediatrician and go to the emergency department is also a very common question. So, if this headache is sudden and severe, what we call a thunderclap headache, definitely emergency room. If the headache has double, if you have double vision, if there's confusion, if you're tired, or if the kid is difficult waking up. I don't like using the word lethargic. I don't use the word lethargic, but when a parent tells me my kid is lethargic, I ask them to describe that, because, just because they don't want to get up from the television doesn't make you lethargic. But if you have difficulty keeping them awake, that may be the sign to go to the emergency room. If there's any associated numbness in any extremity or weakness, if there's associated projectile vomiting, if there's a headache and they're complaining about a stiff neck or neck pain, if there's fever or altered mental status, which is confusion, and especially after a severe head injury. We also talk about red flags. Those are our big warning signs in medicine. I then have a set of green flags, which, may make us feel a little bit more calm and not as worried as healthcare providers. But if we see a patient in front of us and there's a new or different type of headache, if the patient's under 5 years old, or, usually in the single digits and in the older age range as well, if there's abrupt onset, like it came on all of a sudden, going back to that thunderclap headache, if there is a history of cancer or an immunodeficiency, if somebody has like diabetes, those are signs that maybe something's going on. If there's an abnormal physical or neurological exam, and if you're having any numbness or weakness and these are lasting for more than an hour, where we get concerned. And then onset. at the time of the headache onset, was there a seizure? Was there syncope, which is passing out? Or did the headache start with exertion or valsalva, which is that bearing down? And then from a green flag standpoint, if we've established that this headache pattern is stable, it hasn't gotten better, it really hasn't gotten worse, it comes and goes, it happens when they're hungry, it happens when they're tired. So if we're able to establish anything that could be a trigger, if there's a family history, or if they have a history of similar headaches in the past. So this is now painting us a picture of perhaps something hereditary, or this is a norm for them. If there's a normal physical exam. And then going back to the triggers. So every time my daughter gets her period, she has a headache. If every time I eat chocolate or I have cheese or Chinese food, I get a headache. If there's a sensory trigger, such as bright lights, perfumes, and definitely weather changes can trigger those headaches as well. And then if there's variability in the headache, what we call it, it's not a locked position, but it's in the front of your head, the back of the head, the next day it's on the side, it's all over, it's here, it's there. Again, for us, a green flag. So when you get evaluated for headaches, your provider will ask, how often is this happening? How severe? Any triggers? Any associated symptoms? And then we'll have an exam. They'll have a neurologic exam. We may assess vision, make sure visual acuity is okay, because sometimes staring at those screens in class or sitting in the back of the classroom, this may be just a vision issue and you just need glasses. And then taking and feeling the neck. Is there neck pain? Is there just um, tight neck muscles? Our students are very stressed and they carry a lot of weight in their neck. So sometimes just muscle spasm in the neck can cause those headaches. We may or may not do blood tests depending on, again, the rest of the history. Is there a fever? Is there any other symptoms? We may suggest an MRI or a CAT scan. Again, taking the whole picture and the examination into consideration. And depending on all of those as well, a spinal tap may be indicated. So, for our treatments, based on all of our information we've had thus far, in terms of the history, in terms of the physical we've been getting, our goal is to help make your child comfortable. So, what can we give you to help abort this medication? This headache. Most of the time, we will recommend NSAIDs, which is ibuprofen or naproxen, especially if acetaminophen's not helping. There's a category called triptans, which is our sumatriptan. And depending on the age, there are FDA approved medications for the older child. And then what we call GAPANs. So those are some of the newer injectables that currently are FDA approved only for older than 17. So it really depends on the age. Sometimes we can get them pushed through with insurance if we can get approval. But again, depending on um, the age of the patient. But our goal is to tell our patients that you have to help stop the pain early. So a lot of times the kids don't like taking medications and they go 8 hours a day with their headache, and then mom's giving them, acetaminophen at 6 p.m. It's going to be really hard to break that headache. So we want to make sure that they tell somebody right away when the headache begins, and making sure that we're giving the right dose for their weight. So make sure to ask your pediatrician the right dosing as well. For prevention, is especially if you're having in pediatric population, if you're having more than 4 headaches a month, we need to help prevent that, right? Again, that could be affecting sports, it could be affecting dance, it could be affecting family, can't go out to the restaurant. So we really want to help figuring out what your triggers are, and really keeping a good diary and working on things that could be changed, easily changeable. So we break those off into lifestyle changes and then medical preventatives. So from a lifestyle change, sleep hygiene. making sure there's a regular bedtime, 8 hours of sleep a night, no electronics at bedtime. Those electronics get put away out of the room an hour beforehand. Making sure we get good hydration and diet, avoiding skipping meals, making sure there's proper hydration and stress reduction, teaching your child relaxation techniques. And sometimes those anxious, worried kids can, that's what's feeding into their headaches, and then the headaches are making the anxiety worse. So counseling may be something that may be recommended. And then from a medical standpoint, we may recommend various medications to be used on a daily basis, or supplements and vitamins. We have biofeedback or cognitive behavior therapy, and some neuromodulation devices. So some people may have seen Nervio and encephaly. So those things that give some um, um, electrical impulses to help break that pain cycle. So the key takeaways from this is that most pediatric headaches are primary. They're migraine, they're tension type, and then using the history and really trying to figure out what kind of triggers could be causing this is going to be essential to this diagnosis. Red flags require prompt medical attention. And overall treatment may include rescue medications, preventative medications, and lifestyle changes. I do like to point out that if these lifestyle changes could be contributing to the headache and nothing is done with those lifestyle changes, all the medications in the world are not going to help if we can't work on those lifestyle changes as well. So with that, I'm going to hand the torch over to Dr. Penn.
Hi, all. That was really great, Dr. Glicksman. And thank you for having me here. So my name is Dr. Penn, and I'm going to talk to you now about seizures. So I guess, yeah, thank you. So the objectives for my part of the talk is to get you all familiar with the basics of seizures and epilepsy, learn more about kind of what they look like, what can trigger them and cause seizures. I want to explore a bit of seizure first aid and when to seek medical attention, as well as understand the treatment and long-term outcomes of epilepsy. So first, we have to go into definitions. So what is a seizure versus what is epilepsy? So a seizure is an event, and I like to tell my patients that I think of these as kind of electrical glitches in the brain, as opposed to the brain doing what it's supposed to do, whether that's, being alert and responsive or moving a body part, or speaking. The brain gets mixed up and misfires and sends out signals that make our body act in an unusual way. So while a seizure is an event, epilepsy is a disorder or a syndrome in which a person is predisposed to have recurrence of seizures. So that's kind of what distinguishes those two definitions. Okay, next slide. So seizures can vary significantly in appearance based on the type. There is no one type of seizure. A seizure is a sudden, uncontrollable change in either a person's consciousness, movements, behaviors, sensations, kind of you name it. Common signs of a seizure can be subtle as just staring blankly and maybe being less responsive than usual, or can vary into more dramatic body movements, whether that be body jerking, body stiffening or gets very tight, uncontrolled movements like repetitive hand rubbing or lip smacking looking like chewing, or loss of consciousness, which looks like someone passing out and being unresponsive. Some patients get an aura, which is a warning sensation before the seizure, and that can also be very, very, very varied. Sometimes this might be like a rising sensation in the abdomen, but can very much vary. And seizures typically last less than a few minutes, usually seconds. Okay. Next slide. So febrile seizures, I just wanted to bring this to your attention because these are so common. Febrile seizures, febrile means fever. So these are seizures with a fever in young children, 6 months to 5 years of age. And this is different than epilepsy. Most children with febrile seizures do not need medications, and most of them grow out of their seizures with time. These are often followed by a child's pediatrician. Sometimes, though, they do get referred to a neurologist if they become complex in some way, and the pediatrician can help make that decision. But the first time this occurs, as a first seizure, a parent would still seek immediate medical attention. So there are some particular environmental or physiologic triggers that can cause seizures. So things like fevers or infections, sleep deprivations, those can be really common triggers for seizures. Similar to migraines, different changes in the menstrual cycle and hormonal changes. I'll talk a little bit more about that later. Stress in general, whether that's stress on the body or mental stress. I bring up flashing lights as well because yes, this can be a common trigger, but it's actually quite uncommon. Or it can be a trigger, but very uncommon. It just receives a lot of heightened attention in TV shows or in relation to video games. And these factors don't necessarily cause seizures, but if somebody has epilepsy, this can lower that threshold to have a seizure and make seizures more common. So how to know if something's actually a seizure? And to answer that, I'll explain our typical workup for seizures. So the first and the utmost important is the history and the description of the event. This is when videos, if available, can be very, very helpful to a neurologist. So we could really see what you or whatever witness had seen. And then in addition, learning about family history, potential triggers, other parts of the history are really important to us. Exam can be helpful as well. So that's why it's important to, physically see a neurologist. We check for things that might trigger seizures, like an infection or a rash or other signs on an exam that may be associated with someone having epilepsy. And then other tests that may include blood tests. This is sometimes indicated, often ruling out triggers for seizures like infections, low blood sugar, like electrolyte imbalances. Sometimes those can trigger seizures. The big test that most of us use is called an EEG, an electroencephalogram. This is a test where small electrodes are placed on the child's head and they measure brain activity. Kind of looks like an EKG on the chest when looking for a cardiac, like a heart abnormality, but they're placed on the head. And we're looking for unusual electrical activity in the brain that could cause seizures, even if it's between events and we don't capture an event while the patient's on EEG. Sometimes we still see the difference in electrical activity. And then imaging. So a doctor may recommend an MRI or a CT scan of the brain to look for structural problems that could be causing seizures, but this is not always indicated. So importantly, I just want to drive home that while most of this workup is up to the treating physician, the best thing that you can do if you witness a seizure is to really help provide a good history of that to your doctor and potentially a video if that's an option for you. Seizures, pediatric seizures can have a variety of causes. You could see febrile seizures encompass like upwards of 35–40% of all pediatric seizures. And then the next large category is epilepsy, about 1/3 of pediatric seizures. Again, this is that neurological disorder characterized by recurrent seizures that can be due to genetic factors, underlying brain abnormalities, metabolic conditions, or many times an unknown cause. Other factors less common can include like a traumatic brain injury or head trauma, infections such as meningitis or encephalitis, so an infection kind of around the brain, And then there's several smaller categories that are less likely in the pediatric age group. One of the questions that someone submitted is, why do seizures occur at different ages? And I know many of my patients have the same question, as a 13-year-old, why is it happening now? If this has been genetic, if I've had this all my life, why now? So seizures in epilepsy can start at different ages due to a variety of factors, including genetic reasons, differences in brain development, structural abnormalities, and hormonal changes. So I'll go through each of these. So first, starting off with genetics, some forms of epilepsy are related to genetic changes or inherited conditions. And depending on the specific syndrome, there might just be a specific age range where it tends to manifest. So for example, a very common type of pediatric epilepsy is called childhood absence epilepsy. Very commonly, that starts between 5 and 8 years of age. So it's just specific syndromes with specific genetic causes present at specific ages, just kind of the way it is. And then within brain development, there's kind of like two things to think about. So one is that the developing brain is immature and just more susceptible for seizures. And we see that in febrile seizures that only occurs in young infants and children. Their brains are just more susceptible to seizures with fevers. The other thing to think about is within the brain, there's a mix of signals that are excitatory or kind of like make things happen. And then there's signals that are inhibitory or kind of like put a pause on things, stop things from happening. And when there's too much excitation, too many excitatory signals, that can lead to seizures. And kids, while their brains are still developing, they may have too many excitatory signals or not enough inhibitory signals, and that can lead to seizures in younger populations. Structural abnormalities. So some kids are born with structural, a difference in the structure of the brain, like an incorrect formation in the way it is. And this can lead to seizures in young babies, but sometimes it doesn't reveal itself until later in life when the cells of the brain are all connected together and they're more fully engaged and challenged. So sometimes even if something's been present an entire life, it may not present until later in life. And lastly, hormonal changes. So again, similar to migraines, sometimes seizures do not appear until adolescence in the setting of hormonal changes during puberty and changes in the brain activity during that, important period of growth. And then sometimes hormonal shifts can influence seizures as well. So in some young girls, seizures may worsen around the time of the period or in the middle of the cycle, depending on the amounts of estrogen and progesterone, all those hormones that are present. So interestingly, even within the same epilepsy syndrome, sometimes different individual factors can play a role in the timing of seizure onset. So I think this is a difficult thing for parents of kids with seizures to understand, of kind of like why kids are presenting with seizures at different ages, but there's a lot of factors that go into that, I think. Okay. So seizure first aid, what can parents or caretakers do during or after a seizure? So one is making sure that the kid is in a safe position. So what does that mean? You can gently bring or guide the child to the floor if they're standing or sitting to prevent them from falling. You want to make sure there's nothing dangerous in the area, no sharp objects or anything that can cause injury. The best position would be laying flat on the side, helping to keep the airway clear. If there's a lot of saliva, that just can kind of come out of the mouth as opposed to potentially choking. If able and you have a soft object you can place under the person's head, like even an article of clothing, like a sweatshirt or a pillow, in case the head is moving, you don't want that to, cause an injury by hitting on the ground, for example. You, of course, want to monitor the breathing, and if the breathing's stopping, you, of course, want to call 911. And anytime there's a first seizure in general, you want to call 911 for immediate help. You definitely should stay with the child, especially even after the seizure. You want to make sure you're as calm as you can and reassure the child when they gain consciousness that they're okay. They may be disoriented or confused, but you want to be on the lookout, make sure there's no additional seizures, and make sure that the kid is returning towards their normal self, even though they may be sleepy for a while. One bullet point I think I forgot to mention is to time the seizure. So this is really important, because when you see a seizure, it's going to feel like forever. It's going to feel like a very long time. If you happen to be wearing a watch or have your phone near you, just take a glance at it so that way you have a sense of how long it's lasting if you're able to. And if you're able to take a video, for example, if there's other helpers there, that could, be very helpful. Okay. And then when to seek medical attention. So any first seizure, you're going to seek medical attention. Usually the way patients make it to me is like one of two ways. Either they have a first seizure with obvious convulsions, 911 is called, they're brought to the emergency department, and usually they either see a neurologist there or they're stabilized and, follow up with me outside of the hospital. Or there may be kind of like subtle seizures that we're not sure if they're seizures. For example, the school is noticing staring spells and they're not sure if it's attention, behavior, or seizures. So sometimes, I see a kid with seizures after they've been going on a bit because we're not sure of what's going on. But other times to seek medical attention is any seizure with these kind of red flag symptoms. So anything longer than 3 minutes, if there's a cluster or a seizure happens soon after the first one, so there's a few in a row. Of course, if there's any difficulty breathing or if the child's not waking up afterwards, and then if there's an injury during the seizure, which can range, but especially if, for example, a seizure happens in a body of water, like a pool or a bathtub, you're definitely going to want to seek medical attention for that. And then in terms of treatment, we typically start treatment for patients with epilepsy with different medications, and there's many to choose from. There's over 30 different seizure medications at this point, and the way we choose the medication depends on so many different factors. So the type of seizure, how frequently the seizures are happening. We might start, a medication that acts more quickly if they're very frequent seizures, the age of the patient, other health issues. We really have to be very thoughtful in the medications we choose, and we try to pick the ones that will work best for this type of seizure, and of course, minimizing side effects. Sometimes we use side effects for our benefits. So, for example, if a medication has a side effect of weight loss, maybe we would choose to use that in a patient who's overweight or obese, but we would avoid that in a patient who's struggled gaining weight. So we use side effects to our advantage sometimes. And of course, like other drug interactions or medication cost or availability, we always think about. Some medications, it's important to know, can have an effect on a child's development. Specifically, most of these are older medications that may affect attention or learning in children. We don't tend to use these as first-line medications. But the newer medications are much less likely to cause those cognitive side effects. And then I received a question about how epilepsy can affect learning and social development. And I think it's a very important topic because epilepsy can definitely present challenges for both learning and social development, but the impact depends greatly on the severity of the epilepsy and the frequency of the seizures. So frequent or severe seizures can interfere with normal brain activity, potentially affecting attention, memory, processing speed. And then sometimes medications have side effects, such as drowsiness, for example, which can certainly affect your performance in school. And then in addition to those, sometimes there's an underlying genetic difference in patients with epilepsy, and that can cause both seizures and cognitive issues. So sometimes we really have to tease apart what the causative factor is. Sometimes kids need special accommodations in school. if they have epilepsy or cognitive difficulties. So that's definitely something to speak with your provider about. And then in terms of social development, children with epilepsy can feel isolated or different from their peers, and especially if they have visible seizures at school. That can be really tough on kids and may create a fear of having to be around other kids or participate in activities they normally participate in. So I think it's so important to give a lot of positive reinforcement, to give loads of support from family and good friends and teachers. Keep going to school events, keep playing the sports, things that are really important for social development as much as possible. And then my last slide is about outgrowing epilepsy. So many children can outgrow their epilepsy, upwards of 2/3%. This depends on many different factors, but the way we generally determine this is if a patient's been seizure-free over 2 years, then we kind of reevaluate and really try to think about, well, did they outgrow their epilepsy? Do they still need to be on a medication? Things like that. People who are more likely to outgrow epilepsy usually have seizures at a younger age. Typically, if seizures continue past puberty into young, adolescence or adulthood, they're less likely to grow out of them. Of course, the type of epilepsy matters, and as well as your response to treatment. So usually patients who respond really well to seizure medications, of course, go a few years of seizure freedom and are more likely to outgrow the seizures. This is very patient dependent and again, kind of depends on many different factors. And I think that's all I have.
Thank you both very much. That was very informative. So at this time, we'll do a few questions. If anyone has any questions, please feel free to submit it in the Q&A box. The first question is, and you did talk a little bit about this, is it better to call 911 or just go straight to the ER during or after a seizure?
So situational, right? So for example, if it's a first time seizure, you've never witnessed anything like this before, you're at home or really anywhere, I'd say you call 911. You want to make sure that the medical personnel is with your child as soon as possible in case there's a problem from the seizure. Versus if you have a child who's had epilepsy, has had seizures for a while, and you kind of know their seizure type, you know what the trajectory and what the pattern's going to be, but maybe, for example, they had few too many in a short time period, they're back to their normal selves, maybe you can drive them to the ER. So I'd say the rule should be you call 911, but it can be situational if someone's had seizures for a long time.
I like to also add that you have to do what you feel most comfortable doing. No one is ever going to laugh at you because you brought your kid to the ER for a seizure, whether it's the first seizure or the, God forbid, 20th seizure. No one is going to say, I can't believe you called 911 and came here. So you always do what you feel comfortable doing as well. And if not, let your neurologist know. I'm sure everybody's on call. Someone's covering that phone. We signed up for this, and we don't mind getting those calls at 2 in the morning and helping guiding you guys through as well. So we're part of your team. And if you don't know what to do, call your physician.
Thank you very much. The next question is, do anti-seizure medications affect a child's development? And also, how can the disease affect learning and social development?
Yeah, so I think I included that in my presentation. So kind of as I was mentioning that some medications can cause cognitive effects. So they can affect school performance or they can have those effects at times. Usually the ones that concern parents are more of the older medications that had been known to really affect cognitive development, affect school performance. We tend to not use those as first, second, third, fourth line treatment. Those are kind of medications that we really use in specific cases if we need to. So I most of the side effects from the first line seizure medications we use, if kids get them, they're often reversible. You stop the medication, the side effect goes away. So of course it very much depends on medication and whatnot. And I think I spoke about more social interactions and social learning with patients with epilepsy, but if there's a more like specific question I can try to address, let me know.
Okay, thank you. A question that came in, seizures where a child stares off into space and the body goes limp. Is there a specific name for this type? Is this a form of epilepsy?
Great question. So it's really hard to answer those types of very specific questions on a patient by patient basis because I would have to ask you like 20 additional follow-up questions to try to really nail down what type of epilepsy this is. If it is a seizure, we'd probably have to do some testing, that kind of thing. So that sounds like it could be a seizure. It could be one of many types of different seizures. So I'd probably stick with working with your provider on that one and try to nail down the exact type of seizure and epilepsy and if it even is a seizure.
Something similar as an example could happen if somebody is about to pass out and stare off and then pass out. So I agree with Dr. Penn is definitely a lot more follow-up questions and evaluations would need to occur.
Thank you. I have a question about headaches and like taking ibuprofen. Is there like a certain limit that a child should take, or if it gets to they're taking several times a week, um, that there should be some concern about?
That's an excellent question, and not just for ibuprofen, but also acetaminophen, which is Tylenol or Motrin, or even Aleve. Is that if you take too much, you run into the risk of having a medication overuse headache or a rebound headache. So if you find that you're taking it more than 2 to 3 times a week, sorry, 2 to 3 days in a week, then you do run those risks. So you should, speak to your provider about the maximum total daily dose for your child based on weight, and really take a look at that diary. Really important to keep a diary so that way you could try to figure out what it is triggering. And sometimes we do get caught up in, wow, you're taking, these medications 4, 5, 6, 7 days of the week. And the only way to really break that cycle is to stop cold turkey and really see if then that stops the headaches as well. So it can definitely contribute. So that was an excellent question.
Thank you. All right. If anyone else has any other questions, please feel free to submit them in the Q&A. Most of the other questions that were submitted ahead of time, you guys covered in the presentation.